All right, so let's get this program started. We have Dr. Gary Owens. Dr. Gary Owens is here to talk about the ins and outs of insurance and specialty pharmacy. We are supported tonight by Viatris and Sanofi, and we want to take it away, but we want to say thank you to both of those companies for supporting this program. Dr. Gary Owens is a family practitioner. He was practicing for many years on his own, and then he switched and he started working in the what they call the payers world, and he was working specialty pharmacy with Blue Cross insurance. So I'm going to let you now listen to Dr. Gary Owens, and he will talk to you all about this program. Okay, thank you.
Well, thank you very much, Stuart, for that kind introduction, and welcome everybody to tonight's program. I think it would be ambitious to say we're going to understand all the ins and outs of insurance and specialty pharmacy, but I do want to just give everybody an overview of maybe some things that will be very important to you as patients with MS. As you know, specialty pharmaceuticals are certainly one of the mainstays of your treatments, and I think there are some things that are important to know. So as we move forward here, I'll just give you a little bit of background. I was, as Stuart said, a family physician for about 14 years. And then I worked in the Blue Cross system for about 22 years and still am active as a consultant to a number of healthcare companies. And with that, I want to tell you a little bit of personal story of why I have a special interest in multiple sclerosis. As we'll see in the picture that's about to come up, I have a large family. And this is going back in time a little bit because you'll notice the arrow on the right side of the two arrows is me when I still had color in my hair, along with our 6 children and my lovely wife over in the front row on the right. The other arrow belongs to my second oldest son, who, as you can see, didn't get his height gene from me, but somewhere along in the maternal grandparent lineage, he and one of the other boys got that. But anyway, he also was diagnosed now 8.5 years ago with MS, and certainly one of the I've been one of the mainstays of his advisory team. A very close relationship with his MS specialist, with whom I had worked very closely when I was at Blue Cross. So I also have a niece with MS. And so what we're going to talk about, as the slide shows you here, is just some things that I think are new and perhaps different for 2024 and 2025. There's some good news there. There's always some bad news. I'll give a little bit of a background on specialty pharmacy, why we even have specialty pharmacy. And interestingly enough, MS was one of the first disease states, along with growth hormone deficiency, to have specialty pharmaceuticals way back in the 1990s. And then I'm going to close out with just a bit about, well, if things aren't going my way, what are my appeal rights, and a little bit about how you can best work with your treating doctor or MS specialist. So what's new? Let's take a look at some of the changes that we're seeing in insurance in 2024 and 2025. Now, the first thing I want to point out, and I think it goes without saying, is we have a wonderful healthcare system in the United States. We have world-class facilities, tertiary care, hospitals, academic medical centers, specialty clinics in virtually any disease state, including MS. But at the same time, it's a very fragmented system. Unlike most of the wealthy nations in the world, we do not have a centralized medical system. Medicare and Medicaid come the closest, but even they are administered at the state and local level. So because of that, it can often be a complex system. It can be complex to navigate. Coverage, insurance coverage can be confusing. We also spend a lot of money, as you can see here, relative to other wealthy nations. We spend more than twice as much as the average every year on healthcare coverage. We don't necessarily have better healthcare coverage in some of these nations. In fact, on many measures of public health, we're not even in the top 10. But for folks like us who have to take care of ourselves, affordability can be a problem because of this very complex system. So who pays for healthcare? I know it's easy to think it's you and me, and then indirectly it is the case because we're either paying for it in terms of premiums or we're receiving publicly funded benefits through Medicaid or Medicare, which is really paid for by our tax money, or we are getting private health insurance funded by our employers, and the money they're spending for private health insurance is money that they can't pass along in terms of wages or other benefits. So about a third of healthcare insurance is provided by employers in the US. Another quarter of it is Medicare, meaning those people who are over the age of 65 or disabled or who have a few disease states that were mandated for Medicare coverage, like end-stage renal disease by Medicare. Medicaid covers another 20%, and then the rest is paid for by things like individual insurance programs, out-of-pocket costs that are in the forms of co-payments, co-insurance, and deductibles, and then a few things like purchasing collaboratives and other things that make up the pie. But 3/4 of the pie is private health insurance and government. So those are the two largest sources. And so those payers need to really meet what's become known as the quadruple aim. This was a coined term by Don Berwick and his colleagues at the Center for Medicaid and Medicare Services Innovation Center a number of years. What is the aim? The first important, the aim to improve population health, which is really disease prevention, managing chronic diseases, and in general, trying to improve the overall health of the population. Now, the good news is they make decisions that benefit the majority of the population. The bad news is sometimes those decisions don't always make sense for everyone in the population. The second arm of the quadruple aim, or on the left-hand side there in the reddish-orange area, is really trying to improve patient experience. I'm sure all of us have been frustrated from time to time at the experience of receiving or having our healthcare paid for, and we're working to improve that experience, as well as getting patients to play an active role in making healthcare decisions with their physicians, and something I'll close with, the concept of shared decision making. We also want to reduce the cost of care. Remember that previous slide where we spend literally twice as much as the average of wealthy nations for healthcare, which is not necessarily significantly better than what we're getting. And then importantly, and something you may not think about, improving provider satisfaction. We've all been reading, especially in the post-COVID era, about physician burnout, older physicians leaving practice, retiring earlier, frustrations with the fragmented system that we have, frustrations with dealing with multiple insurance sources. And we're really trying to work to provide better tools and better ways to manage insurance coverage to improve that provider satisfaction and minimize physician burnout. So when we think about the largest payer of healthcare in terms of percentage, that a third that is paid for by commercial insurance, that's mostly paid for by employers, those people for whom we all work or have worked in the past. Their top priority in 2024 and beyond is to really manage healthcare costs, because healthcare cost is still growing at a rate that's more than 4 times the general inflation. And if you think about that, it's mind-boggling. We've come through one of the most significant inflationary periods in recent memory, not the largest, but certainly one of the more significant ones, which came post-COVID, and healthcare is going up at 4 times that rate. Employers are very concerned about that. They recognize that every dollar they spend on healthcare is a dollar they can't pass on in wage increases or retirement plan contributions. It's also a necessary dollar because there is a competitive environment for talented employees, And paying for healthcare is one of those things that helps bring out or distinguish them from perhaps the rest of the competition. So they really do have to balance that cost versus retaining their employees. So what does that mean for you? Well, it means that employers are continued to be pressured to manage healthcare costs, and they're looking for ways to control that cost. They often work with benefit consultants, large national organizations like Towers or Aon or others, or even brokers that place their benefits. And one of the things that they've begun to do is have fewer choices. They're narrower networks for which they've contracted at an advantage, networks that their data has told them get better outcomes at lower costs. So you may have actually less choice going forward. And that's going to be especially true if you have an HMO-based product or perhaps a Medicare Advantage-based product. But even the more open network PPO products are seeing more limited choices. And again, you may be seeing that in your area where not everybody that you may have seen in the past continues to participate with your health plan. It's also very likely, as you see over on the right-hand side of the slide, that more money is going to be required from you in terms of contributions to your employer's health plan or in premiums if you're directly paying a premium. And one of the things that we know is drug costs are rising faster than even those medical costs that are rising faster than general inflation. And so more and more aggressive management, things like prior authorization and other management activities are really going to be in the forefront and will be front and center as you receive your treatments. And they, in one way, try to manage cost. In the other way, as we'll see in a few moments, put steps in place that may be difficult or sometimes seemingly arduous for you and your provider of care to navigate. So let's talk about some of those things that might affect you. You may know about some of these. If you do, I apologize. But I think these are important things to know as you work with your doctors or your care team in many cases to get your treatments. So on the next slide, we're going to talk about something called cost sharing. And then after that, we're going to talk about some newer things that may impact your out-of-pocket costs. But I want to show you in the slide coming up just a few definitions so we can level set. Insurance terms can sometimes be confusing, and when we poll the general public, now the MS audience tends to be a more sophisticated audience because you've had to navigate this system, but think about younger people who maybe their only exposure to healthcare has been an occasional visit to the URGI center or maybe even student health if they're in a academic environment. And we know that fewer than half of the people out there even know many of these insurance terms. So I'm going to go over them, and I will apologize in advance if some of them seem old hat to you. The first one is deductible. Very simply, that's what you pay before your insurance benefit starts. So if your insurance benefit has a $500 deductible per individual with a $2,000 family maximum, that means you and each person in your family pays $500 until you reach $2,000, and then your deductible has been met. Copayment, that's a fixed amount that you pay towards a medical service or a drug. So when you go to the pharmacy to pick up your prescription and the pharmacist says your copayment will be $25 or $55 or whatever that number is, that's a fixed amount, and that is fixed regardless of whether that prescription you get costs $100 or $10,000 for that matter. Coinsurance, very different. Coinsurance is a variable amount, usually based on the percentage of the cost of the service you're getting. So if you use that example, a $100 drug with a 25% coinsurance, you would be paying $25 and your insurance carrier would be paying the rest, the $75. On a $1,000 drug, that 25% coinsurance, you would be paying $250 and your insurance carrier would be paying $750. So it's very important to understand that difference between copayment because it's fixed and coinsurance varies based on the cost of the service or the drug. And then, of course, it's also important to know, do I have benefit maximum? Because in some insurance plans, there are maximum amounts allowed towards a service. So if your benefit maximum, say for physical therapy, is 10 visits at $100 each, you will have a maximum of $1,000. That's a ridiculously low number, but I use it just because it's an easy math example. And after that, you would be paying as you go. So it's important to know if there are any benefit maximums out there. Now, the good news is the Affordable Care Act passed back in 2008 or thereabouts, eliminated many, but not all benefit maximums. So what is the reality for you as MS patients? Well, most of your drugs have a high cost. Branded drugs now, the average cost of a branded drug for a biologic for multiple sclerosis can be anywhere from $60,000 to $100,000 plus. We know that your out-of-pocket cost, especially if you have co-insurance, remember that percentage you pay can be significant. And the whole idea of cost sharing was to put forth by payers, including everyone but Medicaid, to create awareness of the public of the cost of prescription drugs. But unfortunately, as the cost of prescription drugs has escalated, and because many of these drugs are really high-tech drugs with a high cost of development and production, it's created those high costs and therefore high out-of-pocket costs, which may be a barrier to your access. And we know that most MS patients do need some form of cost-sharing assistance. I know integral to my son's well-being was a patient assistance program, which he found very confusing, but fortunately I was able to help him walk through that. What we see here in the little graphic that we created, MS and rheumatoid arthritis, a couple of the more common diseases that use specialty drugs. About half of all MS patients, as you see in the lower right-hand corner, and about 60% of all RA patients use some sort of cost-sharing assistance in the last year. And it may even be a bigger number of that going forward. So I think you can probably relate to cost-sharing assistance, whether it be on the commercial side, where that's usually paid for by the manufacturer, or over on the government program side, Medicare in particular, where manufacturers are not allowed to subsidize cost sharing due to federal regulation, but there are funded 501c3 foundations that can help with cost sharing when they have the resources to do it. And that's a big caveat because they don't all have unlimited funds and therefore don't have unlimited resources to help with cost sharing in your case. There's also an unintended consequence. If you remember a couple of slides ago, I pointed out the reason cost sharing was put in place was really, I guess, to give everybody, myself included, a little skin in the game to understand the cost of the drugs and medical services we're getting. The bad news is, the reality is, more than a quarter of Americans have put off medical care due to cost sharing that they couldn't afford. That number actually goes up for people who get specialty drugs or high cost cancer therapies. And about a fifth of people put off filling or don't fill a prescription at all because of cost sharing. So there's some significant realities there. And the reality is care not given leads ultimately to worse outcomes and may ultimately lead to the unintended consequence, yet another unintended consequence of worse outcomes and actually more downstream costs as we pay for more advanced disease. Also, I think it's important to note that the #1 cause of bankruptcy for people over 65 in the United States is medical bills. I'm going to talk about two new concepts that you may have encountered. The first one is copayment accumulator, which I'll define here and give you an example. And then I'm going to talk about one that's even a bit newer, a copayment maximizer. So in a copayment accumulator, very simply, the definition is here on the screen, and that is your health plan stops counting manufacturer copay assistance towards your deductible. So if your deductible is $1,000 and you get $1,000 of copayment assistance, once you have gotten that, then your health plan will say, okay, Mr. or Miss Patient, you now need to meet your deductible before your benefit kicks in. So let's give you a real world example, which we'll see on the next page. In this page, we're going to assume that the cost of your medication is $24,000. That's not necessarily a realistic example for an MS drug, but let's say you have that coinsurance. Remember, it's a percentage, and then this calculates out the $25 a month. And let's assume that there's a maximum copay assistance of $16,000 a year, and that your maximum out-of-pocket cost is $6,000 deductible, and they have a $2,000 deductible. That's a lot of stuff, but I'll walk you through it very simply. Let's look first at the purple bar going across the screen. So in this case, for that $24,000 drug, the manufacturer pays $6,000, which means it's precisely equal to the number second from right in the top bar, $6,000. So you've met your annual out-of-pocket max, which means your health plan pays the rest of the cost of your drug. So in essence, the payer's cost share was $18,000, reduced by that $6,000 of manufacturer assistance. Now let's put in the copayment accumulator. Again, the copay assistance from the manufacturer is $6,000, which means you've reached your out-of-pocket maximum technically, but the manufacturer says because we are now using a copayment accumulator, none of that counted towards your deductible. It did count towards your out-of-pocket max. So now you pay the next dollars, which means that the payer's cost of that drug has now been reduced to $16,000 from $24,000, and by $2,000 more, that is what you paid as a deductible. So it's a way of shifting some of the cost to both the copayment assistance program and still requiring you to pay your $2,000. Okay. Now, what's happening here? It's a growing trend. These are some survey data done by an independent survey organization very recently. And about 6 in 10 payers now offer copayment accumulator programs to their employers. Doesn't mean every employer is going to take one, but certainly many employers do. And I guess the worst news there, over the next 12 months, another 30% plan to expand or implement new copayment assistance programs. So that number is going to grow. You're going to be more and more likely to encounter that copayment accumulator program. But as we've heard in the infomercials in the past, wait, there's more. The copayment maximizer program actually goes one step further. These are the same assumptions. It's that same $24,000 drug, the same copayment assistance that the manufacturer can maximally contribute, which is $16,000. In this case, your hypothetical maximum out of pocket is $6,000, and your deductible is $2,000. And in a maximizer program, what happens, very simply put, is the entire maximum amount of the copayment assistance that you could be eligible for, regardless of what your maximum out of pocket or regardless of what your deductible, needs to be paid before your insurance benefit kicks in. So instead of the copay assistance by the manufacturer stopping at $6,000, which is your out-of-pocket max, it now has to go all the way up to $16,000. In other words, maximizer means using the maximum amount of assistance that you have. But, and the big but is, you still are going to have to pay your deductible. So now you add that 16 to the 2, and the payer or your employer's cost share now gets reduced from 18,000 to 6,000, or in the case of the copayment accumulator program, from 16,000 to 6,000. So you can see this has a profound impact, number one, on the amount of money that the manufacturer will be contributing towards the cost of the drug or service, and still does not alleviate your $2,000 contribution, but does dramatically, actually a threefold reduction in what is ultimately paid for on behalf of your employer or the health plan. So be aware of copayment maximizers. I feel like I've been the bearer of bad tidings, and certainly I don't mean to be. It's not all bad news. More insurers are offering plans that emphasize transparency and simplicity. It's not all voluntary. In the IRA, Inflation Reduction Act, hospital transparency was front and center in that, although we are still seeing many hospitals lagging behind in transparency of their billing processes. But a recent study in the Journal of the American Medical Association, actually published within the last month, the study found that eliminating deductibles in health plans is associated with improved outcomes. That's pretty logical. Remember, I said sometimes that healthcare avoided results in disease progression and therefore more cost. And they've really found that high deductible health plans seem to have more negative impact on chronic conditions like diabetes. And Mercer, which is one of those benefit consultants that I talked about earlier, in their 2024 report, also pointed out that 40% of employers offer at least one low or no deductible plan, and about 15% provide at least one benefit with no out-of-pocket premiums. So there is some shift to help patients with the high cost of healthcare. But again, it's only one plan within usually a multitude of plans within most of these employer groups. So I don't mean to imply that almost half, 40% of employers now have low or no deductible plans. It just means that they offer one plan with low or no deductible. The bad news there is there's always a trade-off. That may mean more out-of-pocket cost, where those that are offering coverage with minimal or no out-of-pocket cost probably have higher deductibles. So you probably can't have it both ways. There's a couple changes I want to mention for Medicare. I think it's good news in Medicare. Based on some of the provisions of legislation that's been passed over the last couple of years. In 2024, you already know this, a person on Medicare Part D, after you pay your deductible, pays 25% of drug costs up to a cap of $3,300, and there's no 5% catastrophic phase of drug cost anymore. The good news is, beginning in 2025, people with Part D plans won't have to pay more than $2,000 in out-of-pocket costs. That was yet another provision of the Inflation Reduction Act. And the other good news is typically that out-of-pocket cost, especially if you were on a high-cost drug like a drug for multiple sclerosis, often came in the first month or maybe 2 months of the year. So in the beginning of the year, when you hadn't met your maximum out-of-pocket in Medicare, you got hit with a $2,000 bill. Now you do have the option of spreading your out-of-pocket costs over the year, so maybe $200 a month for 10 months instead of $2,000 all in January and February. So be aware of that, take advantage of it. In 2005, if it's a budget buster and you really want to spread that cost out, that is an option you will have. Another thing I want to point out, more than 55% in 2024, and that number is expected to go up, have Medicare Advantage plans, which means those are private Medicare plans that roll in Medicare's Part A, which is hospital coverage, Part B, which is physician and outpatient coverage, and Part D, drug coverage, into a privatized plan, which is paid for by Medicare. And these Medicare Advantage plans often offer supplemental benefits, enriched dental plans, vision coverage plans, hearing aid benefits, and fitness benefits. But the sad news is, again, going all the way back to the beginning of my talk, we've got a complex system, and it's hard, especially if you're not intimately familiar with all the provisions, and certainly if you and I know everybody on Medicare gets the Medicare and Me booklet, but it's about a half an inch thick, and I'm sure most of us, myself included, don't read that. About a third of Medicare beneficiaries don't use many of the benefits to which they're otherwise entitled, and many times pay out of pocket for costs that could be covered or subsidized in Medicare Advantage. And again, by law, starting in 2025, I apologize, that small print, you don't have to read it. Basically, you're going to get a mid-year enrollee report from your Medicare Advantage plan in July, and it will list all of the supplemental benefits to which you're entitled, as well as whether you've used them or not used them, and how to really use them to maximize access to those supplemental benefits to which you're otherwise entitled. So be on the lookout for that. Also be aware and do try to make sure you have a good understanding of what those supplemental benefits. But even if you don't, you'll get that report in July and still have a half a year almost to be able to take advantage of some of those supplemental benefits. So with that, hopefully I haven't cast an air of confusion over all of this. Again, I know it's a complex subject. Let's spend a few minutes talking about specialty pharmacy and why we even have specialty pharmacy. Well, we have specialty pharmacy because we have something called specialty drugs. And while there are multiple definitions of specialty drugs, I'm going to cook it down into really a simple term that I think all of us can remember. They're high-cost prescription medications, typically $10,000 a year or more. They're used to most often, but not always, treat chronic, complex condition, autoimmune diseases like MS and rheumatoid arthritis, malignancies like cancer, and certainly lots of other conditions like rare diseases and other neurodegenerative conditions. One of the most recent additions to our armamentarium for specialty drugs are the amyloid binders to treat Alzheimer's dementia. So once we had specialty drugs, which had a lot of cost as well as sometimes very complex requirements for distribution, maybe they have to be shipped cold, maybe they're injectable drugs that you have to learn how to give, maybe they're injectable drugs that a visiting infusion therapist or nurse needs to come to your house to give. We really needed somebody to help manage that, and specialty pharmacies were born, which are distributors that really focus on these specialty drugs and help manage the complexity of these disease states and the drugs for which we are treated. So they, as I pointed out, were created to handle these drugs. In general, you can't take your MS specialty drug to most retail outlets. Now, there are exceptions to that rule. There are some national pharmacies in particular that have specialty drug distribution at retail for selected specialty drugs, and they've contracted with payers to do that. But in general, most of your specialty drug prescriptions for MS need to go to a specialty pharmacy. And I'm sure by now you've formed a relationship with that specialty pharmacy. But I want to give you a little bit of look of behind the curtain, so to speak, at what happens at a specialty pharmacy when your prescription, and we'll take the hypothetical new prescription, although I know many of you are likely to be on prescriptions that have been out there for a long time. The rationale for specialty drugs is that about 5% of an insurance carrier's members use a specialty drug, but it accounts for about 55% in the last year, which I have data, which is 2022, of total pharmacy spending. So that leaves the other 45% of total pharmacy spending in the United States to the 95% of the people who don't use specialty drugs. So it makes sense that we need some processes as well as people who are sophisticated in managing these very significantly costly drugs. So a prescription comes in the specialty pharmacy. The first thing that specialty pharmacy does is, number one, to verify you, the member, has the benefit for this drug. They do that by using electronic connectivity with your health plan. That's why you have to provide your prescription drug card, as well as any Medicare, Medicaid, or insurance cards at the time you see your physician. The specialty pharmacy verifies that you have eligibility for that drug. They verify what kind of benefit you have, what your out-of-pocket costs are going to be. They'll investigate whether you have any assistance in terms of assistance for helping you pay for the drug. And then one of the things that's universally going to happen is prior authorization is going to happen. That means that the payer is going to evaluate that request against evidence-based criteria set aside in medical policy. If all of those criteria are met, the specialty pharmacy can move forward to fulfill your prescription. But in many cases, there's either insufficient information, or maybe one of those criteria wasn't met, or they're unsure whether it wasn't met, and they could be going back to your physician or even contacting you as the patient for additional information. And there's even more, because not every drug is covered by every payer. That's the concept of a formulary, which is a list of drugs that are either preferred or drugs that will be paid for in part or in total by your health plan. And if your drug is on the formulary, again, it leads to a pathway for fulfillment of the drug. If your drug is not on that formulary, it may mean going back yet one more time to your physician to justify why the non-formulary drug is the most appropriate for treatment, something known as a non-formulary exception. So there's all that work that goes on behind the scenes, things that you may not even be aware of until you're contacted by the specialty pharmacy for some piece of information or for payment information. What about prior authorization? Why is it out there? It's used to ensure that the drug benefits are administered as designed. The stated goal is to receive safe, requires prior approval by your provider. In essence and in reality, it's a way to make sure that if a payer, or in this case your employer, if they're a self-funded, meaning they pay the cost of the drug employer, that they are getting the most value for the money they're spending on your behalf. There are two kinds of prior authorizations. There's what's known as the soft prior authorization, which we all hope we have. That one's pretty simple. The doctor prescribes the drug. The diagnosis is confirmed with the prescribing physician. The appropriate prescribing physician, in the case of MS, very likely an MS specialist or a neurologist, and the product is approved. Unfortunately, that's only about 5% of prior authorizations. The other type of prior authorization is the more familiar one. I'm sure you've all engaged in activities with a hard PA. Again, the doctor prescribes your drug. Again, in step 2, the diagnosis is confirmed. In step 3, as I've already pointed out, there are criteria that you must meet in order to get the drug. And if the prescription and the patient match the criteria, the product is approved. And if not, it goes through all of those processes we talked about before, which is getting additional information, maybe correcting a mistake that might be in the prior authorization, or coming up with a medical justification for an exception to the prior auth or formulary rules. So this can take a few days sometimes for all of this stuff to get worked out, which I'm sure many of you have experienced. And I talked about formularies, but why do you want to care about a formulary anyway? So what? It's a list of drugs. If my drug is on it, what's the big deal? Well, basically, formularies have tiers. Like, when I first started in the business, we had 2 tiers of formularies: generic drugs and branded drugs. We now see formularies with 5 and even 6 tiers, where you have the lowest out-of-pocket cost for those preferred generics, the highest out-of-pocket cost for specialty drugs, and we even now have non-preferred specialty drug categories that either may be not covered at all or covered by exception only, and then we have gradations in between. So basically, the tier that your drug is on is very much related to how much you are going to be paying out of pocket, or how much any copayment assistance program or copayment assistance grant you will receive goes towards the cost of that drug. As I said before, it does take some time. Payers are required to turn around these complete hard PA requests in 72 hours, or if it's urgent or emergent, which by Medicare's definition means the patient is likely to undergo substantial harm or deterioration in their condition within 24 hours, then urgent requests have to be turned around in 24 hours. That's the ideal situation. The reality, incomplete requests for additional information go back to physicians, and actually it can take up to 30 days for some of those to get worked out. But once it all gets worked out, once the specialty pharmacy gets your prescription, they usually ship in 24 to 48 hours via overnight shipping. You're usually notified that it's going to be shipped, and you're generally notified are there any special conditions that you need to be aware of, such as you need to be home to sign for this prescription because it has some special storage or handling requirement that you don't want the delivery person from whatever the carrier is to leave it on your doorstep in 90-degree weather. But there is one other caveat. Specialty pharmacies don't ship the drug unless they have verification of member payment, either by payment assistant or by you as the member paying your share through a credit card or some other form of online payment typically. So as we're coming down the home stretch here, I promised Stuart I'd try to keep my talk to about 45 minutes. I have a couple more slides. One is, and I could do a whole talk on the appeals process, but what about if I or my doctor disagrees with a prior authorization decision? Well, number one, it's important that you talk to the specialty pharmacy and or your physician to get a sense of why your drug is being denied. Is it denied because it's not formulary? Is it denied because you didn't meet some criterion? Is it denied because they think the person prescribing the drug didn't meet the appropriate prescriber level? There are myriads of reasons why you could be denied. And you really want to get that evidence. You want to keep all of that documented in writing. Certainly have your physician send you anything, because you really do want to talk to them. And then on the back of your insurance card, there's always a number you can call for customer service to initiate an appeal. And you want to contact that number and initiate a member appeal, as well as begin to give them the reasons. And typically they will send you an appeal form, which you can then fill out with all the information. The more documentation you have, the more likely you are to be successful in your appeal. Definitely, if you feel you have good justification, appeal that decision. There are very strict rules on how payers at both the state level as well as the federal level for Medicare Advantage plans, and that's well beyond the scope of tonight's talk, have to follow for those appeal. And if you continue to get denied, I will just point out that every state in the country has at least 2 levels of appeal, including one at the health plan and one at an independent organization. Many states have 3 levels. And interestingly enough, Medicare has 5 levels of appeal, all the way up to federal district court. So typically the first 2 or 3 levels of appeal are what most members use in Medicare, but you are afforded 5 levels of appeal in Medicare. And so as I promised, I'm going to close this with, I think, some of my best advice to you. And with all this complexity in 2024 and beyond, one of your best allies is your provider and the staff that they have, because they can really help you in what's known as shared decision making. And one of the concepts that's been put forward is the concept of shared decision making, and the term called SHARE, which is really just an acronym, which is number 1, get your providers participation. Talk to them about not only the clinical decisions that you and your provider are making, but as well as maybe talk to their staff about financial decisions. Physicians are encouraged to really help you explore multiple options. The old days of I'm the doctor, here's what I want you to do, and don't question my authority are long since past. Physicians are encouraged. They're also encouraged, other staff, to really think about some of your values and preferences. Your values might be different than my values. I might be wanting to be able to do more travel. You might be wanting to just be more comfortable and have less pain. So it's important that your physicians understand your values. A lot of times values differ by social and cultural norms. And it's really important that the two of you reach both financial and clinical decisions as a joint decision. And then I think it's important for both you to evaluate your decision and how is it working out, and do I need to change course? Even the best navigator sometimes needs to make course correction because of unforeseen circumstances, and your physician is encouraged to evaluate that decision. So with that, I think I've probably stayed exactly my welcome time. I'm going to invite Stuart back in, and I think we have some time for questions if you have it.
Hey, I'm back. Thank you very much for doing this presentation. And I wish that I could say we had a lot of questions, but people don't have a lot of questions this evening. So I'm going to ask you a couple of them. The first one being,
more than welcome.
The first one being, are all specialty pharmacies created equal?
I would say specialty pharmacies are like people. When you've seen one specialty pharmacy. They all have different rules. They operate generally under the same umbrella of effectively managing specialty drugs, but they're going to have different formularies. They're going to have different ways to interact with them through portals and websites. Some of them have big staffing to outreach to you as a patient to make sure you're taking your medication, and if you're not, are there things they can help you with? Are you having side effects that they might be able to help you manage? Some of them help you with financial assistance, others don't. Some are very large national firms, which means if you're one of those people that maybe migrate from the Northeast in summer to the South or Southwest in winter, they can provide for your needs wherever you are. Others are more local or regional specialty pharmacies. There are even specialty pharmacies that specialize in cancer drugs, neurology drugs, rare disease drugs. So again, they're very much like us as the population in general. There's a lot of diversity in specialty pharmacies.
Thank you for that. So with regard, though, to the specialty pharmacies, if pharmacy A is selling a specific drug, let's just say instead of ABC or XYZ, let's say STU, all right? And if they're selling STU drug and another specialty pharmacy is selling an STU drug, do they charge the insurance industry the same, or do they have different pricing?
Another one, it all depends, and it depends on the contract that they have negotiated with the insurance carrier and sometimes directly with the employer. There are specialty pharmacies who employers contract directly with, just like they do with PBMs, to provide non-specialty drugs. And in fact, some specialty pharmacies are owned by PBMs. So what a specialty pharmacy gets paid for the drug is 100% based on the terms and conditions of the contract they have with the employer, the health plan, or whomever they contract. And very often you can't shop around for your specialty pharmacy because your health plan or your Medicare Advantage plan may have a contract with one or two specialty pharmacies, but not with all specialty pharmacies, just like they do with PBMs. Now there's those new entities arising like Mark Cuban's Cost Plus that if you're going to pay cash for, you can go to them and see what they offer a drug for, and they often, if you're going to have to pay out of pocket for it, they often can provide you with a drug, just like GoodRx can sometimes get you deals. But specialty pharmacies differ in what their contract is, and basically what you pay, because you're mostly paying insurances at a specialty pharmacy is based on what the contracted price is with your employer or health plan. So what you pay can vary significantly with the contracted rates they have.
Okay, thank you. Belinda online asks, are drug companies now pulling back their patient assistance programs to help those in need of help with their copays?
You know, I haven't seen a lot of pullback on that yet. I think they are trying to look at other strategies they might be able to use in the era of copayment accumulators and copayment maximizers. But I mean, it's a good thought that if, I mean, these are big corporations and they do have to turn a margin to stay in business and to develop new drugs. And if ultimately the cost of copayment assistance erodes that too much, they may have to rethink some of that copayment assistance that's out there. But fortunately, I haven't seen a lot of that yet. I don't know if any of your members have experienced that or report that to you, but I haven't seen it yet.
Okay, thank you. The last question that I have is, will outcomes of the election do any harm or changes to specialty pharmacy?
God, I wish I had a crystal ball, and I'm going to say that I think whichever party is predominant in 2025 and beyond is going to be confronted with the high cost of medical care and will likely put forth legislation. Now, it may be very different depending on whether it's a red or a blue Congress. I really don't know. But I think we will see new legislation. I mean, some of the provisions of the Inflation Reduction Act are just coming into play now, and those go forward into the next 3 or 4 years or even the next decade. So some of that's already built in. But what else is going to happen? I'm not clairvoyant enough to know, especially if there's some deeply in Congress. I'm being polite now. We may look for more stalemates than change going forward.
Right. Okay. Well, thank you for your presentation this evening. And I wish we had more questions, but I guess the world knows more than we do these days. Okay. So
either that or there's just so many things. It's hard to, it's bewildering. I recognize that. And certainly there are organizations, advocacy groups that have now sprung up to help everybody negotiate this, and take advantage of those too. That's my closing advice.
That's right. Okay. Well, have a great night. Thank you for joining us. And for everybody online, we hope to see you at our next program, which is tomorrow evening. Thank you. Bye-bye.
Bye now.